Start.
Start, huh? Okay. So today we'll be describing a case of primary recurrent pregnancy losses with diminished ovary reserve. Here, with diminished ovary reserve. So this is vaginoscopy. We can see all the cornices are normal. External os can be seen clearly, and external os can be seen clearly. So this is the external os. External os. We'll try to negotiate this easily. We are able to negotiate it, and now we are in the cervical canal. So cervical canal we can see normal in appearance. So this is the level of internal os. This is the level of internal os. So let us see whether internal os will get dilated spontaneously with the help of irrigating fluid. So we are negotiating the internal os right now. Yes, slowly just slide the telescope through the internal os. We are sliding. So here the main problem is primary recurrent pregnancy losses. So we are in the endometrial cavity. This is the right ostia, appears closed. This is the left ostia. So going back to pathophysiology, physiology says that endometrium consists of two layers. One is superficial layer, the other is basal layer. Superficial layer consists of a single layer of columnar epithelium which rests on the stroma, and basal layer is other the basal layer. Superficial layer is the layer which is shed with the menstrual blood. So basal layer is permanently there, and it consists of stem cells which give rise to superficial layer for the development of the endometrium and then subsequent shedding. So basal layer and superficial layer is supplied by the spiral arteries which are under the control of estrogen as well as progesterone. If progesterone is not available, that is, pregnancy does not occur, these spiral arteries undergo ischemia and lead to shedding of the endometrium. We can see here features of chronic endometritis are here. So chronic endometritis can lead to recurrent pregnancy losses. Many causes of chronic endometritis, and one of the important cause is genital tuberculosis in our setup and society. So little bit of immunology is here, that for successful implantation to occur, we should have Th2 response. T helper 2 response is successful for implantation, whereas Th1 helper response antagonizes implantation. Any type of infection and inflammation lead to Th1 response inside Th means T helper 1 response that antagonizes implantation and successful pregnancy. So here we take a biopsy from the cornual ends of this endometrial cavity, from the ostial ends. Slight indentation here. Let us check the anterior wall. So chronic endometritis, we will give her a good course of antibiotics. Antibiotics for at least 21 days with linezolid and as well as clarithromycin. Else, if biopsy is positive for tuberculosis, then we can put this patient for on ATT. Mirai Saab will give me scissor, will do lateral metroplasty as well as slight release of additions at the fundus. So we are inserting 5 French scissor through an operating hysteroscope now, and we will do two things. We will do the lateral metroplasty here. The aim is that this should be, left ostia should be visible from the level of internal os. This is both operative as well as this is known as diagnostic as well as therapeutic hysteroscopy. So we can see the lateral metroplasty has been done. Yes, lateral metroplasty has been done. Now we can clearly see the ostia from the level of internal os. So no need for lateral metroplasty on the right side. Fundus is slight arcation will release, slight arcation at the fundus. The guide for releasing arcation at the fundus should be bilateral ostia. Okay, both in terms of depth as well as in terms of the site for release of fundal arcuation. So always undercut as compared to overcut. So we can see the myometrium clearly now. So Umair Saab will slightly zoom in so as to have better video. Yes. So this is the fundal arcuation we have released. Once you cut, there occurs recede, endometrium recedes, myometrium recedes. Recession of myometrium occurs. So 3-4 things to be noted. Important is both hysteroscopic as well as laparoscopic findings. If both hysteroscopic and laparoscopic findings show that she has genital tuberculosis, so then we'll put her directly on ATT without waiting for the report. This is, we can see clearly, beautifully that this is the myometrial vasculature. Gentle. We'll reduce the intrauterine pressure. Yes, we can see the bleeders for the myometer. Can you see it? Yes. So these bleeders are not of much worry to us. So we have released the fundal arcuation and we have resected nicely. Thank you and greetings from Kashmir, India. Thank you. God bless you.